Welcome to NMP Talk Show, the show that keeps you well informed with topics regarding your mental health wellness. And we're happy that today you are joining us from far away, wherever you are seated there. But we know that you are with us. We can see you joining us even on Telegram. We really appreciate you. And we apologize that we are not able to stream to Riverside, our usual platform. There's some glitches there. We don't understand what's happening. But yeah, we always have a plan B on this. So today, as you can see, our studio is different. Usually you see the black background. Today we're in a beautiful office. But before we tell you which office we are in, I'm with my co-host. And for the first time in 3 seasons, we're sharing a space together. Figile, welcome.
Thank you, Noah. It actually feels good to be in the same space with you.
Yeah.
In real life, we were used to communicate virtually. We run the show virtually, but today we are here. But hey, just a little bit of house rules, Noah.
Yes.
Today, as much as we are not streaming live on Riverside FM, but we are on Telegram, we are live on TikTok, we are on YouTube as well. So if you've got any questions to ask our special guest, you are welcome to type them down, and then we will read it out for our special guest, and they will be able to give you an answer right there and then. Who is our guest today, Neo?
Before we go to our guest,
Yes.
if you want to, as always, want to have a comment or ask a question, you can raise your hand there on Telegram, and then we will be able to unmute you. Yes, and also, speak to our guest. So today we have a special guest. We've been trying to get this guest of ours, and finally we did it. We were hoping to have her last year, but this is a good timing. Everyone is relaxed. Everyone is trying to get into, the stream of things, in terms of getting back to work and school. And there are things that really concerns us that we really need to talk about. And these things affect our mental wellness. And one of those things is diabetes. Diabetes is one of the pandemics that we have to contend with. And we brought a professional to help us with that. Now, which diabetes are we talking about? We're talking diabetes in the eye. You may wonder, how do you have a diabetes in the eye? She's going to explain that to me. So today we have Dr. Raman-Abdulla, who's joining us on the show. Welcome to our show,
Good
Dr.
evening.
Leila.
Good evening. Thank
You can
so
move your
much.
yes, yeah.
Okay.
Yeah.
Yeah. Thanks so much for having me. It's
Oh,
really
yes.
lovely to be here. And I think it's just a really nice way to start off the year.
Yeah.
Just taking stock of our health
Mm.
and getting ready for a good year ahead. And it starts with empowering ourselves with that knowledge.
For sure. For sure. And thanks for allowing us to interview you. In fact, this is not an interview; it's a
Conversation.
the conversation, of course.
Yeah.
We want you to relax and just tell us what you know about this pandemic. But who is Dr. Laila Raman-Abdulla?
That's an intense question. I think the short version is that I'm an ophthalmologist.
Yeah.
Which basically means that I specialize in everything to do with the eye, health and disease, and if necessary, I'm able to operate on the eye. So that's my passion. That's my speciality. And a woman is so many more things than just the things she does.
Yeah.
But I think that uh, medicine and the practice of the speciality is really a calling for me. And it is one of the key things that define me. And I'm so privileged to be able to be on this platform today and take the message out there into our community. Because I think that topics like diabetes, mental health, how these subjects tie into each other, can become a very academic conversation when it comes from, a public health platform. But when we have these kind of discussions, having a conversation, the community joining in, I feel that's a powerful way to get the message across. So
Get
I
it.
think, I guess, a part of who I am is an advocate of health.
Oh, beautiful.
That's great.
Beautiful. Thanks for that introduction. And now everyone is settled. They know who we're talking to.
Yeah, I think
Yes.
so.
And just to let you know, our precious audience, this episode is being sponsored by Camelot. Camelot is a company in Randburg that uh, uses technology. So if you're looking to hire cameras, video cameras, sound, anything that has to do with audio visual, Camelot is the place to go. So today they've sponsored this program of ours. They've given us cameras, lighting. It's such a beautiful thing so that this show can go on and we're enjoying it. Now, doctor, let's get back to you.
Mhm.
We talked about diabetes.
Yeah.
You know, how big of a problem is this diabetes?
Neo, it's a very big problem.
Mm.
And I think that my speciality, eye health, ophthalmology, I think we've undersold what a big problem it is.
Mm.
Because if I put it in a context for you, diabetes is the number one cause of blindness in working age adults. I mean, just, think about that.
Mhm.
For people who are economically active, contributing to our fiscus,
Mm.
this condition is the biggest threat to them. And this is worldwide. Whether you're sitting in the global north or the south, diabetes is a leading cause of blindness in working age adults. And in South Africa in 2023, there was a survey that was done looking at the prevalence of diabetes in South Africa. And like I say to you, okay, the prevalence is 12%,
Mm.
but just put that along HIV, which is sitting at a prevalence of about 13.7%.
Mm.
Now, diabetes is very close to that figure, right?
Mm.
So it's just as a serious problem as HIV is in this country. And yet I feel it doesn't get the publicity or the awareness in our community that HIV
It
gets.
deserves.
Yeah.
Mhm.
And if you put that into numbers, I mean, that's like 7 million South Africans
Ooh.
sitting with diabetes, and that's costing our country 2.7 billion a year, 7 billion rand a year. And that is excluding taking into consideration that people with diabetes are also then at threat of losing their jobs. They can't work, they cannot be economically active. And so I think it actually, if we think about all those things, it probably costs us a lot more.
Mm.
So sadly, we have a lot of work to do.
Yeah.
And it is a big problem. And that's why we're having these discussions today, right?
Yeah,
Yeah.
definitely. Yeah.
Yes, I just wanted to know in what type of diabetes does this vision problem that we see in diabetes of the eye, is it the type 1, type 2, what is it?
Yeah, so diabetic eye disease and any sort of eye problem can affect type 1 and type 2 diabetes. So
Okay.
if you're at home and you're sitting with diabetes, it doesn't matter what type you have. The way diabetes affects your eye in both types is pretty much the same. But of course, we know that 90% of people are type 2 diabetics. So, often you're going to be seeing it, I suppose, more in type 2s.
Okay.
But, across the spectrum, it doesn't matter what type of diabetic you are.
Okay.
Okay. So here's another question for you.
Yeah.
If you are diagnosed with diabetes, how long does it take you to lose your vision or your vision to be affected?
So, it's not a straightforward answer,
Mhm.
but let's say you diagnose with diabetes today. You're looking at about 5 to 10 years before you're actually seeing serious diabetic complications.
Mm.
The thing is, though, that when you are diagnosed with diabetes, you don't really know how far along in the disease it is, right? You could have been walking around, and this is the reality. You could have been walking around with diabetes for years, actually, because type 2 is actually not, what can I say? It doesn't manifest, it doesn't necessarily manifest severe symptoms. And there's some people out there who are living their lives, who are very used to having a dry mouth. They're used to going to the toilet 5 to 6 times a day. They're used to feeling fatigued. So and they can go years like this, right? And so they've got diabetes. So when they come to you, they might have been diabetic for 3 years. So I think my message for people who are newly diagnosed, and I think most health professionals who diagnose a person with diabetes would say, day one, once you have diabetes, that's the time to actually ensure that you see your ophthalmologist, your dietitian, your podiatrist, and then of course your physician. And these are the people you need to be seeing on an annual basis. You shouldn't be waiting for this magical figure in your mind, 5 years or 10 years. And really, when it comes to blurry vision as a diabetic, diabetes can cause severe, like blurriness caused due to severe disease, or blurriness that's not as serious. So if you're diabetic and your sugar goes over 10, your vision can suddenly get blurry, and that's because the glucose rushes into the lens of the eye and changes the prescription temporarily. Now that blurriness, it goes away once your sugar comes back down. So you could have a lot of water, you might have taken your medication, the blurriness goes away. So let's say you're diabetic, you've just been told you're diabetic, and now you have this blurry vision that comes and goes. In your mind, you might be thinking, well, it goes away. So,
Why is it, doctor?
it's not serious. I just need to drink a couple of cups of water and it's going to be fine.
Yeah.
And we kind of tell ourselves these stories, Neo, like, in our mind, we rationalize it. We say, oh, maybe I wasn't really blurry at 6 o'clock in the morning and I'm fine now. And so it goes on like this. But the truth is that blurriness can one day come and stay and can be due to very serious complications behind the eye.
Yeah.
And I think that's why, diabetics need to sort of make friends with their health professionals that are managing their diabetes. They need to feel comfortable saying, once a year I'm going to be seeing you, because there can be more serious complications, and these complications are preventable.
Sure.
Yeah, very interesting. But now tell me, Doc, what are the risks of getting diabetes in South Africa?
I think when it comes to type 2 diabetes, the biggest risk there has been shown to be a hereditary risk, right? So you've got family members, you're sitting at home now, you're thinking, well, what's my risk? If you've got a first degree relative with type 2 diabetes, that's probably, a big one. And you need to be
It's a
probably,
red flag.
it's a red flag.
Yeah.
But the interesting thing that came out from this South African National Health and Nutrition Examination Survey last year was that if we look at, for example, an Indian demographic in South Africa,
Yeah.
they are 3 times more likely to actually have, diabetes. But then when they looked at a Black demographic, what was interesting was the thing that was increasing their risk was the psychosocial stresses. The fact that these are the homes that have the most amount of social deprivation. I mean, South Africa has the highest Gini coefficient in the world, 0.7, which speaks to the level of social inequality and deprivation. I mean, some people are still dealing with food insecurity in 2024. So interestingly, in this study, what they showed was that overcrowded households, low income households, people who were facing unemployment, if they were borderline diabetic, they were more likely to become full on diabetic and actually have worse complications because of the psychosocial stresses in their households. And this is why, and this is what they saw in a Black demographic, that the prevalence of diabetes was more severe, and there was higher risk in getting diabetes because of those risk factors. So that's really interesting. And I think I have seen that in some of my patients, because if there's just a bowl of porridge to eat, you can't be choosy about that.
Yeah.
If that's all the money that this household has, you've got to make difficult food choices. And it's very easy for us to say, well, let's, have a salad and a chicken breast. But if you don't have the luxury of making those food choices. So I think one of the biggest things that came out of that study is our lifestyle is really putting us at risk. We know the genetics, but the lifestyle and the stress
Yeah.
of modern day life. And 30 years ago, we were doing studies about the causes of diabetes, the stock standard: alcohol, smoking, age, hereditary. And now we're doing studies about, like I'm saying, the psychosocial aspects of it, because 30 years into democracy, there's been rapid urbanization, and you find that people are really facing the reality of financial stress, trying to secure shelter, trying to secure food security for their homes. And then if you have a diagnosis made in your life and you the primary caregiver, you the earner in the home, and you've got school fees to pay, you got some tough choices to make. And I think that's really the challenge now for health professionals in the industry. That's the public health problem that is diabetes. Because you've got to address so many other, it speaks to so many other social issues. And it's not as simple as saying, here's your medication
Yeah.
at the clinic and go home. Yeah.
So, doctor, let me jump in there quickly. Um, from my lack of knowledge, I thought diabetes is the result of a lifestyle. And when I'm talking about lifestyle, I'm talking about, going wild,
Yeah.
eating whatever comes your way,
Yeah.
don't care about the fat or whatever comes in there. And you're talking about the risk that the research has shown now that in Black communities, especially those in poverty stricken, they are more likely to, if they are borderline. Did I hear right?
Yes, yeah. If they have a hereditary risk, right?
Oh, they
They've
should
got,
have.
they've got a
Okay.
hereditary risk, and now they're more likely
Yeah.
to go on and manifest full-blown diabetes. Yeah.
That's interesting.
Very much interesting.
Yeah. So those that are connected on Telegram, if you have any questions so far, you're more than welcome to raise your hand and ask. And ask the doctor here about diabetes. If you have an experience as well, maybe you've gone through that, or you also, have it because of hereditary, like some of us. One of the things that can help us, or you and I, to move forward so that we're able to cope with this pandemic. I'm saying this is a pandemic because, like the numbers that she stated, a lot of people are diagnosed, and some are not even diagnosed.
That's
They don't know they're diagnosed.
That's
They're
it.
just walking with that disease. Is that a disease?
Yep.
Yeah, I want to be sure. All right. So now you spoke about blurriness in the eye,
Yeah.
and you mentioned glucose
Yeah.
has to do with something like that. What really happens in the eye, in the back of the eye?
Yeah. So I think this is the thing. If you're diabetic, what you know is that high glucose, right? And it's very difficult sometimes to reconcile how does high glucose translate into eye damage. But we've got to actually think about what it actually does to the different parts of the eye. And, in the body and in life, everything is about balance and homeostasis. And, in the body, you have to have like the right balance. And when there's an excess of glucose in the body,
Yeah.
which in a diabetic, which is usually the case because the body is unable or incapable of mopping up that glucose, right? So there are different mechanisms and it's all quite technical, but essentially the body, it can't handle the glucose that's coming in, even a little bit of glucose, in a diabetic, it's just too much for the body to handle. And so the glucose is busy circulating. And then into the eye it goes. All right. And when it comes to the front of the eye, it goes into the lens of the eye. So the eye is very much like a camera. And this is what I always tell my patients. The eye is a camera, it's got little components in it. And one of the components in your eye is a lens, a lens that basically your eye takes pictures with, it focuses your light, it directs the light to the back of your eye.
Okay.
Now, if the glucose keeps going into the lens when the glucose is high and then rushing out and going in and rushing out, so of course it will when the sugar drops, it leaves, right? And then when sugar goes up, it goes back into the lens.
Okay.
And this kind of in and out of the lens causes the lens to change and causes the proteins to change. And this then causes the lens to become cloudy. All right.
Okay.
So diabetics are 2 to 3 times more likely to develop what we call cataracts. So the
I was about
moment,
to ask about that.
yeah. So the moment you have this cloudiness in the lens, you get cataracts, and that's when the vision starts to drop, and you really feel like there's a mist over your eyes. And diabetics are more likely to develop cataracts earlier. So I'll often have diabetics who are driving, who are still working, and the blurriness I was telling you about, suddenly it doesn't go away one day. And they're like, I've been struggling to drive. I'm driving at night, I can't see the number plates.
Yeah.
And these are patients who now are developing diabetic cataracts.
Okay.
So that's diabetes affecting the front, like the front parts of the eye. But the back of the eye, that has to do with actually the tiny little blood vessels at the back of the eye.
Mm.
So diabetes is very much a condition that affects the tiny blood vessels in the body. And what it does is it actually ends up damaging the lining of these blood vessels, making these little blood vessels leak.
Mm.
And when these blood vessels leak, you must think about it like this. If you have a pipe and the pipe bursts, the water pressure goes down, right? You open your tap,
Mhm.
much less water is coming out or no water is coming out.
Mm.
Now, in the eye, the moment these little blood vessels start to leak, the blood supply to the tissues to which those vessels were carrying the blood, they now start getting deprived of blood and of oxygen. So diabetes actually now causes this deprivation in blood supply. All right. So that's why diabetics start losing sensation in their toes and their fingers, on the very tips of their toes and fingers, because the small blood vessels get affected there and cause a neuropathy. And then they also end up damaging the blood vessels in their kidneys, so they get kidney failure. And then in the eyes, you find that this leakage in the back of the eye causes poor blood supply to the tissues of the back of the eye. So the battery's dying. Yeah. Right. And it's difficult. You can't just recharge it, unfortunately, as much as you would want to. And so the body tries to compensate by making more blood vessels at the back of the eye. And unfortunately, though, those blood vessels that are then produced, they are actually not healthy. They're not normal. It's a desperate attempt by the eye to try and compensate for now this. It's like one of those quick jobs that you do. You have a burst pipe in your house, and you don't have the budget, and you try masking tape it. So the body, in a desperate attempt, tries to make more blood vessels to compensate. And these blood vessels are abnormal and they bleed even more. And so you find these tissues getting waterlogged with blood. And all of a sudden, what is supposed to be a totally transparent, clear medium in order for us to get a lovely quality image, now all of a sudden that's not there anymore. And when you're getting to that stage in diabetes, it's pretty serious and it's difficult to treat. And that's why we want to start picking up these issues beforehand. When you start to see the leakage, that's when you want to actually start intervening, not when the pipes just completely burst and you're sitting down the line now trying to mop up a very bad situation. It's better to just actually pick it up when you see, one or two are starting to leak. Now you can make the lifestyle changes. You can say, you know what, doc, I need to backtrack very quickly on this and give my eyes a break and give my body a break. Because I think we don't, consciously feel the stress sometimes we're putting on our body. The organs are telling us, things aren't going well, but, in our minds, you kind of talk yourself out of it, right? It's just like, I'm fine, I'll keep going. But it's very important. And if a diabetic is waking up one day and they suddenly lose vision, it could be quite a massive bleed at the back of the eye. If they're seeing floaters, this could also be blood at the back of the eye. So it's very important that diabetics don't delay when they start having these serious complications as well.
But now it's when they notice or they know that they're diabetic.
Yeah.
The problem is some of us, we don't want to go to the doctors. There's this thing about men. They'll be sick, but they'll never go to a doctor.
Yeah.
They'd rather sleep it off and all of that.
Yeah.
I don't know if it's a stereotype way of looking at things. But as you mentioned, once you see these signs or these signs coming up, you really need to consult. But here's another twist. Growing up, I only knew diabetes was for old people.
right?
Same. Yeah.
And now it's the leading cause of blindness in working age adults. I mean, that's the kicker, That's the thing. It's working age people.
For me, it's
Yeah.
unthinkable to have.
Now, as we're sitting here, I'm thinking,
Mm.
you mentioned quite a few. I'm trying to diagnose myself. And I'm like, I think I need to make a consultation and come and see the real doctor
Yeah.
instead of me diagnosing myself.
Yeah.
I mean, I wouldn't. Yes, my grandmom is diabetic and has been diabetic for almost all my life, know.
Right.
So now I'm thinking, it's something that I always thought it's for old people.
I'll get there.
I mean,
time.
when I get to her age, maybe I'll think of consulting. But what will you recommend? Because you're now talking about the working age that contributes to our economy.
Yeah.
What will you recommend to the viewers and the listeners out there that they need to be aware of, or what is it that they need to look at for them to not form part of the status?
Okay, so I think the first thing is we all need to make reality our friend.
Yeah.
Yeah.
That's the first thing. So, like you're saying, okay, you acknowledge your grandmother has diabetes. Like we've said, you've got a genetic risk. And now we've seen, based on the studies, based on the data that's coming out, that psychosocial stresses are more likely to push us into getting diabetes
Yes.
earlier and more serious. Okay. So, first of all, you have to have an honest conversation with yourself. I mean, I think that I myself, as I'm hitting my 40s, you feel, it's a lot. Like you say, you think, am I really that old? Like, do I really need to be having these conversations with myself?
Yeah.
But you do. And you really need to interrogate your families, your siblings, your parents, your grandparents. All right. You need to know what's lurking in your family. It's not just diabetes. Mental illness is a big one because that often hides in families. Cancer, hypertension, cholesterol. We need to have these conversations with our family at the table. That's where you can start because we don't like to talk about these things. But I think we need to get more comfortable sitting around our table with our family and having these conversations and saying, hey, mom, did grandma suffer from X, Y, and Z, or did you? Or, when you went through this change in life or menopause, did you get these symptoms? Did you get suddenly diagnosed with diabetes? When did you get diagnosed with diabetes? You'll be surprised. Some people will tell you, well, I actually got diagnosed in my 30s or my 40s.
Sure.
I've just been living with it for all these years. Right. And because our grandparents always seem old to us, you'd think that, but they might have well been diagnosed at 40.
Yeah.
Right. That's the first thing. The second thing is look out for signs of diabetes. Guys, be honest with your diet. You know what you're doing. You know if you're stopping and you're getting that takeout. You know if you're having processed food and sugar 5 days a week. If every single day you're putting processed food into your mouth, we're talking biscuits, cakes every day. Be honest with yourself. And then look and say, okay, am I feeling fatigued?
Yeah.
Am I feeling that I have a dry mouth all the time? Am I going to the toilet frequently, especially during the night? Do I have frequency? And then when you're walking in the mall, pop into, there's so many like the Clixes and the Discoms and there's so many little places that you on your Saturday morning run can literally be like, can I just quickly check? I mean, I've seen these little even practices next to spas and checkers, they're there. Just go in and do it. Like, or at work, when the nurse comes to work and says, guys, at your tea break, I'm here. And you're like, no, not today.
Nah, I'm not sick.
No,
I'm
not
not gonna
there.
see you.
Just check it. Check it twice a year. It's out there. It is there. And even government, public health, they've made it accessible. You go home to your family. December when we make the mass migration.
Yeah.
Let your you go like you haven't seen your granny or your mom for a while. Let's go and do it. Let's go and do a quick check. Let's both of us go and do it. We have to be proactive. And I know what you were saying now about okay, you're a man, and it's hard to get there. But I think our community needs to understand this. What is the alternative? What is the alternative? You are, for most men in this country, you are the primary earner for your home.
Yeah.
You are the one putting bread and butter on the table. So, like, what is the alternative? You suddenly going to wait one day to wake up blind? You're suddenly going to wait to just have a heart attack? And there's this old adage that we talk about in medicine that women get sick, but men die. And that's because that's men. They let themselves get to that point where they just wake up one day and then they drop dead because they've neglected themselves to that. So really my message to community, to young men out there is to just think about what's sitting on your shoulders. You know, there's a lot of people that have put their trust in you, that are depending on you. And I know that's a lot, but you've got to recognize that you have a responsibility to take control of your health. You know, I have people coming to me, I have drivers coming to me saying, and are diabetic, and you know they need the treatment, but they're like, no, I just need to make this one drive to KZN, then I'm going to come back, then I'm going to come. And I'm like, but if you come back from KZN and you are blind, you're not going to make any more runs. That's it. You're off work. You've lost 2 months of income. I have the same problem with our miners. You know, it's no work, it's no pay. So they're having these negotiations with me. But I'm like, you need to think about the bigger picture here. You know, what is the alternative? The long-term consequences are far worse.
Yeah.
And I think men sometimes they just put their bodies on the line. Women too. I mean, we need to stop doing that. We need to stop sacrificing our bodies for the other things that we need to provide in our lives. And we need to realize that it's only one body we have, you know, and we have to just love ourselves. And I'm telling you, we've got all the knowledge, we've got all the access. We can open our phone today, and there's so much of information out there. And yet it's like we just can't get to that level of self-love where we say, it's me first. Where we tell our kids, or our wives, our spouses, our family, it's me today. I need to take this day off. I need to go and see the dietitian. I need to see the eye specialist. I have to make this time for myself. And we have to.
Yeah. But you know, all that is, it makes sense,
Yeah.
you know, and it hits home. But there's another factor that we also think about, the costs.
Yeah.
You know, some got medical aid covers that, you know, are okay. And you have those that don't have medical aids at all.
Yeah.
And now you speaking about going for checkups. Now it's money for bread or going to checkup.
Yeah.
Something must be sacrificed.
Yeah.
Do we have like from the hospital, public hospitals, a way that we can get checked?
Yeah.
You know.
Absolutely. And I think, you know, and this is not just what you're saying is so true. And it's also true for middle class, because a lot of middle class people just have hospital plans and they have to pay. They have to pay out of pocket for their GP visits, for their specialist visits. I'm going to say that a good place to start are your clinics. The West Rand has 45 clinics through which 3 optometrists rotate. Once a week, they would go to, you know, each clinic, the 3 of them rotate.
Yeah.
So in the West Rand, all you need to do, the thing about it is you have to take a day. Okay. So it is going to mean that you have to sacrifice a day of work, your off day, but you can present yourself to a clinic and you can say, listen, I'm diabetic. I need to see the optometrist. And the optometrist is your first base, and they're able to screen you.
Yeah.
They're able to have a look at the back of your eye and assess. They're able to pick up if you have a cataract. If you've got double vision, they're able to assess. So they can do a pretty comprehensive screening. And then they're going to channel you to where you need to go.
Okay.
Also, our general practitioners, right? A general practitioner cash going to set you back about $400.
Yeah.
But that's also a good place to start. I am not where people should be starting to screen for their diabetes. You need to start with your general practitioner, your optometrist, your local clinic.
Yeah.
And then they're going to look. And let's say the general practitioner looks in, or the optometrist at the clinic, and they say, oh, well, Neo, I don't see any cataracts. Looking at the back of your eye, everything looks healthy. You only need to see an eye specialist again in a year.
Yeah.
And then you can actually save toward that.
Yeah.
Yeah.
Then you've got a year to save towards that eye specialist. But you start off by subjecting yourself to screening.
Yeah.
And then, you'd find that even places like Specsavers, Tolga Optical, there's so many optometrists out there, guys, that actually do screening.
Yeah.
And it's not in the hundreds and thousands. It's a small fee. You say I'm diabetic, and you have a look at my eye.
Yeah, you're talking about people who are diabetic. Now, I was just thinking because I do most wellness days, and I do see the optometrist coming through to some of the companies I visit, and you see the number of people that visits those stores. It's very little. So I would like to say in this show, it's people that you need to visit more, as much as they're not going to give you anything for free, but the consult will be for free, I'll say, because they do your eye testing.
Yes.
And they test for diabetes.
Yes.
It's people that we don't visit most of the time.
This is
That's where you can start to say, okay, let me just pop in 5 minutes and then it's done. If the doctor says, or maybe the nurse is there and says, okay, you need to see a specialist. Don't take it lightly. At least your employer gave you the entrance,
opportunity, yeah.
And then now you can move forward.
absolutely. And
Just before you go in there, would you have someone raising their hand? Dr. Itessa, welcome to the show. I'll just unmute you there.
okay. Thanks, Dr.
No
Tessa.
problem.
I appreciate the question and your support. So I often get these urban legends and these horror stories that float up from time to time, patient to patient. And I think we've got to be very careful about taking one story and taking anecdotal evidence and then translating it into, well, this is the outcome. And I think as a community, we have to reinforce the fact that, yes, some people do suffer complications from surgery. Every surgical procedure has risks. And even being diabetic puts you at risk of a procedure. But I think that, and I do this with all my patients, I always talk about the benefit versus the risk. The likelihood of having complications after cataract surgery or through any procedure involving eyes is very low. Actually, eye surgery is considered a low risk specialty compared to other disciplines. Okay, so that's the first thing. The other thing is that I always try and bring a patient back to focusing on their situation. We don't know. Somebody tells you a story. I had an auntie in Limpopo who went for cataract surgery. Patient got blind. There are so many. There's background that's missing. We don't know what the patient's vision was beforehand. We don't know what happened in theater. We don't know if the patient was blind beforehand from diabetic illness plus had a cataract, and then you remove the cataract and unfortunately nothing changed because there was severe diabetes at the back of the eye. So I think that we have to sort of encourage the community to see health professionals as their support. We're here to help. There are these horror stories here and there, but this does not speak for the majority of patients. There are a lot of patients, and this is the thing, success stories don't get enough coverage.
Exposure.
But I mean, I was showing you that picture of a patient who changed their lifestyle, went into cholesterol tablets, 3 months down the line, vision's back, eyes looking 10 times better. There are so many working class people that are getting back to work, getting their license again, because they're proactively treating their diabetes, they're going for cataract surgery. So, over the years, I've treated thousands of patients for cataract surgery. And I can still to date count on one hand how many have had serious complications. And I can tell you, it's not just a routine run of the mill, oh, this patient had a complication, they're blind. There's always a backstory. There's also other things that compound that patient's situation and why they went on to have the complication. So I just encourage, doctor and all of us to shut down the negativity, because everybody needs to run their own race, you need to walk your own path. And the truth is that there's
like a limitless amount of evidence to show that if you get treatment sooner, if you get cataract surgery, you actually can reverse and prevent your blindness.
Yeah.
You know, before I met Dr. Abdullah,
Mm-hmm.
I had stories and beautiful stories about her.
Okay.
And I was told she was the best around this area.
Mm-hmm.
So I can vouch my life for her that she's the best. And I have proof of it.
Mm-hmm.
You can ask me after the show, where do I get the proof from?
That's where you're from.
I will
That's
definitely I will
okay.
definitely share. Dr. Itessa, I don't know if the question was answered nicely. You can move on to your next question.
So, Dr. Tessa, I'm not familiar with that study, but I've also seen this that patients on insulin um, are more likely to be presenting to me on with cataracts and more advanced diabetic eye disease. But I've always interpreted as that prior to going onto insulin or being on insulin is really an indicator of their control. And often, by the time a patient ends up on insulin, and that's the sad thing, and it still exists even in our South African culture, that people want to go on to insulin as a last resort. um, I find that in for younger people, they're more willing to, but I find that the middle age, slightly older patient, for them going onto insulin is like I've failed. It's like if you most of my diabetic patients, if I say to them, I see you riding at 15, 16 on your glucose, and I keep seeing this, and I keep seeing your eyes are not looking that great. Don't you want to go onto insulin? Don't you want to see your physician? And they're like, no, no, that's admitting.
Oh no.
That's admitting defeat. So I from my experience, I think it's just it is because I think they are patients who are more uncontrolled, and because they wait much longer to get onto insulin. But I would love to have a look at that study if you could just pass it on to Neo, because it'd be interesting to see whether or not if you started a patient day one alongside each other, with the same sort of glucose and the same control, would it speak to the insulin itself? But my experience is telling me it's probably because they're those patients that are more uncontrolled.
Sure. Sure. So is diabetes, you have type 1 and type 2, right?
Yeah.
Are they both reversible or only one type?
Diabetes is, and I think Dr. Tessa will speak to that. I mean, agree with me when I say it's not diabetes. There's no cure for it. It's not reversible. It is what it is, and it's manageable with medication. Now, are the complications of diabetes reversible? Yes. Okay, but I'm never going to get to a point when I can miraculously make my body, handle glucose better, unless you are a very early diabetic and you're really strict about your diet and your exercise. But those are also patients who are physiologically in a better position. They to start with, they were better with metabolizing their glucose, and they've got a little bit of insulin.
Okay.
But you cannot, like with a type 1, it is what it is. They just can't make insulin or enough insulin. And so that's not reversible. But I think that you can simulate a state where you can trick your body into believing that it's making its insulin by giving it to it, or taking medication that makes the body mop up that glucose. And you simulate that to a point where you're unable to suffer the complications. And sometimes you have those complications, and if you're very strict about your lifestyle, your diet, your medication, you're disciplined, you can reverse the complications.
All right. I think she's speaking to the next question that I wanted to ask. But before I get to the question, a lot of YouTube videos. I'm seeing tons of YouTube videos. They talking since I've posted this show. This algorithm will just flood you. Will flood you with
The echo chamber.
I know, right?
Right.
Somebody's listening there. and whatever we're talking here, you see when you start to Google and something will come up there. But in any case, I'm seeing a lot of videos talking about the type 2 diabetes being reversed. And yes, the common theme there that I've seen is the diet, the food that you eat. Now, here's a question that relates to it. How do I then slow it down or slow the progression of diabetes and reduce the risk of me going blind? Yes.
Yeah. And I've also seen those videos,
Mm.
and I think you know, patients, there's a massive obesity problem, worldwide.
Mm.
Okay. And a lot of patients who are obese are dealing with something called insulin resistance,
Okay.
which is, not exactly full-blown diabetes. And I think a lot of those videos speak to insulin resistance, where the body has just become so accustomed to that diet, that processed sugary diet, that they develop this point where the body actually now cannot metabolize that glucose effectively. So I think when we talk about reversing diabetes, I think what people are speaking to is reversing insulin resistance, which is very possible. If you're a 140 kilo male and you drop down to 90, you now have you're now more sensitive to insulin. The insulin that you always had, you were just resistant to it because you had that amount of glucose and your diet was that messed up. So we can sometimes almost induce a diabetic state into our bodies, right? But when you have like a genetic, conclusive diagnosis of diabetes, and now you for yourself want to slow down complications, you have to. There's three things you need to discuss with your doctor.
Yeah.
HbA1c, it's a blood test, okay, glycosylated hemoglobin. The simple explanation is that this protein will give you an idea of what your average glucose control is over 3 months. And you need to know that figure in your mind.
Yeah.
So you have a conversation with doctor, you say, what is my HbA1c? You take it, and then as a diabetic, you need to get it to be less than 6.
Okay.
Yeah. So I know we're wrapping up, so
No,
I'm
you
just
can
gonna
carry
quickly,
on.
I'm just gonna tell you 2 other things. So yeah, the glycosylated hemoglobin needs to get down, and you can do that with lifestyle and with being disciplined about your medication. Then it's your blood pressure and your cholesterol. Now, many diabetics are out there saying, but I don't have blood pressure and I don't have cholesterol. But a lot of diabetics also don't check this.
Yeah.
No.
They don't want to get another diagnosis.
No.
So guys, please have this conversation with your general practitioners, have this conversation with your physicians. Your blood pressure needs to ideally be on the lower side when you're diabetic. It needs to be like, a lot of people are sitting out there with 150 over 90 and they think, well, that's normal. No, guys, it needs to needs to come down to 130 over 80.
Okay.
And then cholesterol, I know that a normal cholesterol of 5 is acceptable for a lot of people who are not diabetic, but if you're diabetic, your cholesterol should be less than 4.
Okay.
And it really plays a big role in slowing down the progression of eye complications.
Yeah.
So a lot of practitioners are now just putting their patients on a cholesterol tablet, even if they don't have, by definition, cholesterol, to get that cholesterol even lower, so that even if the blood vessels leak in the eye, the amount of lipid leaking into the retina is that much less.
Yeah.
And the diabetic eye complications are much less. So just remember, we know the lifestyle thing, but those 3 things, HbA1c, blood pressure, and your cholesterol test.
Yeah.
Make sure you have that, bring that up with your practitioner.
Okay.
Okay.
Wow. That was actually quite a mouthful. Thank you very much, Doc.
It was a lot of information.
It was, and I still have a question. Maybe this would be my last question to you.
Okay.
I'm just echoing what you said, and also posing a question there. You say if you're diabetic, your cholesterol should be less than 4.
Yes.
What is the lowest, which is the risk that you should not get to?
Oh, you mean like what figure in
Figure,
your mind
yes, yeah.
you shouldn't be?
Yeah.
You shouldn't be above 5.
Okay.
Okay, above 5
That's
and then
more-
below?
Mhm.
And you should. Oh no, but look, you can go obviously less than 4, but I've never seen a cholesterol less than 3 on treatment.
Yeah.
So
Okay.
I've actually, so I don't think it's a thing where you have control, like you can actively in your mind say,
I'm
I got-
fighting to get to that number.
no,
Yeah,
no,
yeah.
no, no. I think you just
Yeah.
got to take the tablet and watch your
Okay.
diet.
Okay.
And
that's
it happens sort of naturally, and you sort of you go with your practitioner and you'll sort of go back and forth and have these discussions, and
Yeah.
and every 6 months or once a year you take these blood tests,
Okay.
and then you have that conversation.
Okay.
Yeah.
Okay.
Awesome. Thank you so much, Doctor. This was very informative. What did you say?
Actually, it was very much informative. I do
Yeah.
believe that our audience out there, they got what I got, quite a mouthful. One thing I will say in closing is that thank you very much, Doc, for
Thank you.
granting us the opportunity to have these conversations, which is
In her
conversations in her office, which is conversations we always run away from.
Yeah.
I did say when we came in earlier to say, you become intimidated when you go and visit the doctor's room.
Yeah.
But after this show, you doctors are going to become my friends, because I'm looking at what will be at risk in the long run,
Yes.
as compared to me shying away to visiting the doctor's rooms. Thank you very much.
Thank you so much. And I also want to thank everyone that has joined the show today. We really enjoyed your comments, and I know you have tons of questions, but it was time that ran away from us. And we apologize for the glitch that we had in the beginning. But as you know, nothing is perfect here. But we were able to make another plan. So we're happy that you're able to listen to the show and also comment on it. And I want to also express my gratitude to you, Doctor. Really appreciate it. I really appreciate it. Hopefully, we might have you back on the show one day with another topic. We don't know. We don't know how the year holds for us.
Good luck, guys.
Thank
All the
you.
best.
And another gratitude to Camelot for providing this equipment, sophisticated equipment that we're using today, the microphones, the headphones, the cameras, the lighting. They transformed this office into a studio, a full-on studio. And we really want to thank the team at Camelot. So if you want to hire equipment, they're the person to go for. Just when you get there, just tell them you heard from NMP Talk Show, and then they'll sit in the deal for you.
Yeah, they'll sort you out.
They will sort you out. So thank you so much for joining us. And my name is Neo Morapedi, the host of NMP Talk Show. I'm with my co-host Figile Nkosi for the first time that we can even hold hands on the show. And we're signing out.
Thank you.
You need internet? You need